Imagine your body's healing system gets so confused that it actively starts erasing your own anatomy. Learner, welcome to the deep dive.
Yeah, it's a pretty heavy thought to start out with.
It really is. Today, we are looking at your notes on lichen sclerosus, or LS, and we're synthesizing data from some major UK and European clinical consensus guidelines. So groups like the BSSVD and IUSTI, alongside some really comprehensive patient management protocols.
Right, the real foundational texts for this condition.
Exactly. And our central mission today is tackling a critical question that, well, it historically gets brushed aside in generalized medical overviews. And that question is, can lichen sclerosus cause chronic pain?
And it's such a vital question, because LS is far too frequently mischaracterized. People think it's just a simple itchy skin condition.
Right, just a superficial localized itch.
Exactly, which is totally wrong. When you actually read the clinical data, you are immediately confronted with this deeply complex, multi-systemic cascade of pain. To really understand the why behind the pain of LS, we have to look past the surface. We need to examine the physical architecture of the tissue and, frankly, the nervous system as well.
Okay, let's unpack this. Because before we get into the hidden nervous system stuff, we really have to establish what LS actually does to the body at a structural level.
Yeah, the physical reality of it.
Right, so looking at the sources, LS is a chronic inflammatory, likely autoimmune condition. And it's often linked to other autoimmune issues, right? Like thyroid disease or diabetes.
Yes, and what's fascinating here is that researchers consistently identify specific antibodies in these patients, specifically extracellular matrix protein 1 or ECM1 antibodies.
Okay.
Yeah, and ECM1 is essentially the biological glue of the skin. It holds everything together and gives it elasticity. So when these antibodies attack that protein, that elasticity is just destroyed. This isn't just cosmetic. This is the foundation of the mechanical pain patients experience, because the disease is fundamentally altering the skin's barrier and its physical structure.
Wow. So epidemiological data suggests this affects an estimated 1 in 100 women, though the sources note that's probably a massive undercount due to underdiagnosing.
Absolutely. It's wildly underdiagnosed.
And it also affects men and children. But visually, the sources describe it as creating these pale white patches. The skin thickens in some areas, or it gets really thinotrophic. Dermatologists literally describe it as having a cigarette paper appearance.
That cigarette paper description is spot on for the atrophy.
Right, it's paper thin. It primarily affects the anogenital area, so the vulva and perianal area in women, often in this like figure of 8 pattern. And in men, it affects the glands and foreskin. But the analogy that comes to mind with that cigarette paper skin, it's like an old, dried out rubber band,
Yes, exactly.
Like a brand new rubber band stretches easily. But if it's old and dried out, it's lost all its elasticity. It's incredibly fragile, and it's just prone to snapping under any tension at all.
That is the perfect way to visualize it, because that fragility shifts us right into how these physical changes manifest as acute and chronic mechanical pain.
Right, the actual day-to-day experience of it.
Exactly. The primary symptom is this intense, relentless itch. And of course, the natural response is to scratch.
Which you shouldn't do, but it's human nature.
You can't help it.
Yep.
But because the skin is like that dried out rubber band, scratching further damages the fragile tissue. You get severe bruising, which clinicians call ecchymosis, and these awful blood blisters.
And then the fissuring starts, right? The sources talk a lot about fissuring.
Yeah. The skin develops these incredibly painful cracks. They're essentially severe paper cuts, and they happen from minimal friction.
Like what? Just walking around?
Literally. Wearing tight clothes, sitting down, or just using toilet paper. The skin just splits.
Ugh, that sounds agonizing. But it gets worse because over time, this chronic inflammation leads to scarring and fusion. The sources describe the labia actually shrinking and fusing together, burying the clitoris, and narrowing the vaginal entrance and choroidal stenosis.
Right. And you see similar structural changes in men and children, too.
Wait, so the body is essentially gluing its own anatomy together. How does that even happen?
Well, it's a pathological cycle. You have intense inflammation,
Yeah.
right? And then these raw, fissured surfaces are constantly resting against each other.
Because of the natural anatomy of the area.
Exactly. So the body tries to heal the cracks, but it gets confused. It bridges the gap between two raw surfaces and creates scar tissue that binds them together. This architectural distortion is a massive primary driver of functional chronic pain.
I mean, obviously. The sources mention severe dyspareunia, so pain during penetrative sex and dysuria, which is severe pain and stinging when urinating.
Yeah, urine hitting those open paper cuts is excruciating. And for men, this loss of elasticity causes painful erections and phimosis, which is a tight, unyielding foreskin.
And it impacts kids, too, which is heartbreaking. Little girls especially, they often experience painful defecation because the perianal skin is so tight and tears so easily.
Which creates a terrible behavioral loop. They withhold their bowel movements because it hurts, which leads to severe constipation, which just makes the tearing worse the next time.
God, that's just a continuous cycle of trauma. But here's where it gets really interesting,
Mm-hmm.
because the physical damage explains the mechanical pain, right? But the sources pivot to this crucial hidden complication.
Your neurological side.
Yeah. What happens when the skin actually heals, but the pain remains? The guidelines explicitly state that if LS is successfully treated, the skin looks okay, but the patient is still symptomatic with burning or soreness instead of an itch, doctors have to consider a coexisting condition, vulvodynia.
Yes, vulvodynia is chronic vulval pain, and it is nerve-related pain without any active identifiable skin disease. The visible LS might be managed, but the nervous system has been completely rewired by the trauma.
Right, so it's like a car alarm that keeps blaring long after the burglar has already left the neighborhood. The initial threat, the LS flare, is gone, but the nervous system is still just stuck in overdrive.
That is a brilliant analogy. The nerve endings have lowered their threshold for pain, so even a light touch feels like burning heat. And this leads directly to another major issue, pelvic floor dysfunction.
Because the muscles react to the nerve pain.
Exactly. When you have persistent pain from LS or vulvodynia, the pelvic floor muscles involuntarily tighten. It's a protective reflex. But this constant muscle spasm creates a secondary, incredibly debilitating source of chronic pain during and after sexual activity.
So the pain syndromes just layer on top of each other.
They absolutely do, which makes diagnosis and treatment incredibly difficult if doctors are only looking for visible skin changes. They'll say, well, the skin looks fine, so you must be cured, while the patient is still in agony from muscle spasms and nerve firing.
Which brings us to the psychological weight of all this. Because chronic pain never exists in a vacuum, living with this constant physical and neurological distress severely impacts a patient's broader life.
The psychological burden is just massive. The sources show high rates of depression, anxiety, and a really severe impact on sexual quality of life and relationships.
I mean, understandably. The fear of tearing or bleeding leads to an understandable drop in spontaneous desire. Low libido isn't a mystery here. It's self-preservation.
Yes, the brain is actively avoiding trauma. To combat this, the sources suggest psychosexual counseling and something called sensate focus.
Sensate focus, what's that?
It's essentially a structured way for partners to explore touch without any pressure to perform penetrative sex. It helps retrain the brain to associate intimacy with safety rather than anticipating pain.
That makes a lot of sense, rebuilding those neural pathways.
Yeah.
And on top of that, patients carry this background anxiety because there is a cancer risk.
Right. There's a 3 to 5% lifetime risk of developing squamous cell carcinoma.
Which means they require lifelong surveillance. They have to constantly check themselves for lumps or non-healing ulcers in an area that is already traumatized. So what does this all mean?
Well, if we connect this to the bigger picture, treating LS isn't just about treating skin. It's about restoring a patient's quality of life, their intimacy, and their peace of mind. We have to consider the sheer mental endurance required to live with an invisible, painful illness like this day in and day out.
It's a heavy burden, for sure. So let's talk about reclaiming comfort. Having explored the depths of the pain, how do the sources say it can actually be stopped or managed?
The gold standard, universally agreed upon in the guidelines, is a super potent topical steroid, something like clobetasol propionate.
Clobetasol. Okay, but you can't just use it whenever, right? The guidelines specify really strict usage metrics.
Yes. For example, during the initial treatment phase, a standard 30-gram tube should last precisely 3 months.
That's very specific.
It is. If you use it up in a month, you're applying too much and risking thinning the skin further. If it lasts a year, you're under-treating, and the inflammation is still secretly causing scarring. The goal isn't just to stop the itch, it's to halt the scarring process entirely.
Okay, what about daily habits? The sources mention washing.
Right. Soap is completely out. It strips the skin's barrier. Patients need to abandon soap entirely and use medical emollients for washing.
And for the pain of urinating, the dysuria we mentioned earlier, the sources recommend a really simple pain relief hack, using a peri bottle.
Yes, it's so simple, but so effective.
Yeah, you just squirt warm water over the area while peeing. It dilutes the urine in real time and physically washes the acid away to stop the stinging.
It's a lifesaver for patients during a flare. But we also need to talk about topical anesthetics. The guidelines have a very specific warning about lidocaine.
Right. While numbing cream, like 5% lidocaine, can help with ambient daily soreness like if you just need to be able to sit at your desk comfortably, the sources explicitly advise against using it for penetrative sex.
This is a critical point.
Oh, wow. That is a massive light bulb moment. You'd think numbing the pain is the goal, but if you can't feel the damage happening, you're just making the scarring worse tomorrow.
Exactly. The patient won't feel themselves tearing. They won't know they're pushing past the tissue's physical limits. So they trade a pain-free experience in the moment for long-term, potentially irreversible anatomical damage.
It really highlights how crucial patient education is. You can't just hand someone a prescription. They have to understand the mechanics of their disease so they can safely self-manage and avoid those structural changes.
Education is absolutely the cornerstone of treating lichen sclerosus.
So, to summarize our central mission today, can lichen sclerosus cause chronic pain? The answer is a definitive, multi-layered yes. It causes mechanical skin destruction, fissuring, scarring, architectural fusion. And it causes secondary nerve and muscle responses like vulvodynia and pelvic floor spasms.
But, and this is a crucial part, rigorous, disciplined treatment with super potent steroids can halt that destruction.
It's manageable. But before we wrap up, I want to leave the learner with one final fascinating mystery pulled from the source material.
Ah, the epigenetic theory. I love this.
It's wild. So we established earlier that LS is associated with ECM1 antibodies, right? The immune system attacking the skin's glue.
Right, the standard autoimmune model.
But some researchers now suggest these antibodies might be epigenetic, meaning they are the result of the disease, not the cause of it.
It's the ultimate biological chicken and egg scenario.
Literally. Is the body randomly attacking itself to start the disease? Or is some unknown trigger destroying the tissue first, and the body is just producing antibodies in the aftermath to clean up the wreckage?
If it's the latter, we are looking at the immune system entirely wrong. We're assuming the cleanup crew is the demolition team.
Exactly. Learner, I invite you to ponder that one, what is truly setting the fire. Thank you for joining us on this deep dive. Keep questioning, keep learning, and we will catch you next time.